Hello. Thank you all for joining today's Leveraging Women's Voices and Experiences to Inform the Strengthening Systems for Safer Childbirth initiative, virtual seminar focusing on India. We are thrilled to be speaking here to you today. White Ribbon Alliance is hosting this event in support of the launch of Strengthening Systems for Safer Childbirth, and to help provide a roadmap for community coalitions interested in expanding their work to include direct engagement of women as part of strengthening solutions for addressing maternal mortality. Over the course of this seminar, we will be covering What Women's Want's groundbreaking open-ended question methodology, which puts women's and girls' demands for quality healthcare at the center of the policy decision-making process. We will be also sharing in-depth examples from India on the What Women Wants campaign's grassroots mobilization process and national level outcomes. We will be highlighting the What Women Want methodology, its key findings, approaches, and results. And a large focus on this seminar will be showing how to use the What Women Want database to drill down on women's demands and identify multi-sector linkages to foster more holistic solutions as part of the Strengthening Systems for Safer Childbirth, EOI. Before hearing from our colleague from MSD for Mothers, who will share a little bit more about the Strengthening Systems for Safer Childbirth initiative, I wanted to introduce myself and my partners. My name is Christy Cade, and I am the CEO of the White Ribbon Alliance, and also co-chair of the Global What Women Want campaign. I'm thrilled to be joined by my colleague, Dr. Arpajita Gogi, who is the National Coordinator of White Ribbon Alliance India, and is also the Executive Director of the NGO C3, the Center for Catalyzing Change. She is also co-chair with me of the Global What Women Want campaign. Thank you so much for being here, Arpajita. I know everyone will be thrilled to hear you speak about the campaign specifically in India. I now would like to pass it over to our colleague, Timoteo Egebago, who will share more on the Strengthening Systems for Safer Childhood initiative. Over to you, Tayo.
Hi, everybody. It's really great to be here, and thank you, Christy, for the warm welcome and introduction. I'm Timoteo Egebago, the Global Advocacy Director for the MSD for Mothers initiative. And my role here is just to really to tell you a bit more about the Strengthening Systems for Safer Childbirth initiative and the motive behind this this initiative, and what we also want you to be able to pull out of this session in order to be able to respond to our current expression of interest that's out, and to tell you a bit more about the process and timeline for the initiative. So if you go on to the next slide, please. I think the first thing to say is that this whole initiative was driven out of four major issues that we saw in terms of responding to the current maternal health crisis in many respects in different geographies. The first is the lack of progress in terms of meeting the SDG targets in reducing maternal mortality across the globe. At the current rate of progress, we really need to double our efforts if we're going to meet the target for reducing maternal mortality across the globe. And when you look at places like Africa in particular, where the burden is greatest, we're not going to hit those targets until 2085. So there's really a need to really help accelerate progress here. Whilst I acknowledge that there has been quite significant progress made in India, I think we will all accept that basically, we still have way too many women dying from giving life. The next is basically the funding gap that exists when you look at the need in terms of the health system and wider infrastructure that's required for RMNCH across the globe. There's the Global Finance Facility estimates that there's something like $33 billion annual deficit in our MSH funding, which has only been exacerbated by the pandemic. And then the pandemic itself has put an enormous strain on the wider health system, and also specifically on maternal health services delivery and uptake. We see that basically, even in places where we've seen huge gains, such as in India, there's been a regression in terms of some of those gains, in terms of delivery of care, the quality of care that's been delivered, and people accessing care. So there really needs to be a response if we're going to to make sure that we do not lose the gains that we've got to date. But also, as I mentioned earlier on, actually that's one thing, but we actually need to be accelerating progress if we're actually going to make the target in the first place. And then last but not least, and I think what really we feel very passionate about is that too often the priorities in terms of response to all those needs tend to be driven from a top-down donor-driven priorities versus what the communities are saying that they want and how is it that they're saying that they want it addressed, and being able to actually elevate some of the local solutions that exist, given what I've just explained in terms of the issues at hand. It is clear that basically we are not going to be able to address some of these issues unless we look inwards. And so I see some of the great solutions that already exist in some of these the geographies that we're trying to address these issues in. So one of the things that we really want to dive into is to be able to actually understand what is going on the ground, and how do we respond to those issues with local solutions that integrates women's voices and their priorities in response. You go to the next slide. So the Strength System for Safe Childbirth initiative really want to put local actors in the driving seats. What does that mean? It means supporting multisectorial coalitions to work in particular states, districts, or at a country level, where we're implementing evidence-based solutions that respond to local priorities, as I said earlier on, by local and being led by local organizations. Other things that we want to really scale and integrate contributions from local private sector in mixed health systems. It is clear that basically private sector is playing a huge role, and again, another thing that was surfaced or brought to the fore during the pandemic response is that the private sector in a lot of these sectors are playing a huge role in terms of the delivery of care in these geographies. And there is a lot of opportunity to be able to strengthen systems, efficiency, responsiveness, resilience by capitalizing on that capacity to respond. And then looking at leveraging existing investments, what we want to really try and do is not to reinvent the wheel, but see how can we leverage what others are already doing, so that we can actually all augment each other's efforts. It is clear that again, given constraints, even without the constraints, the best way to actually advance is to actually build on each other's work and collaborate to make sure that we create synergies. And then last but not least, we want to fuel collective action and learning, and bring other co-funding approaches to the table, where we are creating a community of practice, so we can actually learn from this effort as we go forward. Next slide. So in terms of the timeline for the rollout of this initiative, so I wanted to spend a few minutes just to explain what that is. We launched the initiative back in September, on September 14th to be precise, and up to now there's been an expression of interest out, which will welcome responses from those on this call. And by joining this call, I'm assuming you're interested in responding to that expression of interest. That is due on the 15th of November. We'll be taking a month to review those expressions of interest, and then informing successful candidates that we're advancing their proposal on the 15th of December. and then we'll be spending, or partners in conjunction with those that responded, we're spending so between December and March next year to develop those proposals further for a full final proposal that's will be due on March 31st. And then we expect to take a couple of months to do those proposal reviews, and then begin contracting around May 2022, with a view of being able to actually kick off work in July of next year. So that's kind of like the timeline to this work. I hope that those on this call will be able to really, or to one, respond to our expression of interest, and also be able to actually help us in terms of developing these ideas around how we ensure that those proposals that come forward and the principle behind making sure that women are at the center of the proposals that are being developed and we're responding to their needs is something that becomes more of a norm than an exception going forward. Next slide. So thank you very much. That's all from me. I'll pass it back to Christy and the team, and I'll be online at the end to answer any questions that folks may have. Thank you.
Thanks so much, Shayo. And yes, just please, if you do have any questions during the presentation, feel free to answer them and ask them in the chat box, and we will make a note of them to ensure that your question gets answered in the end. For those of you who are less familiar, WRA, we're a global network whose mission it is to propel a people-led movement for women's and girls' health and rights. When we formed more than 20 years ago, it was because the voices of women were being unheard, resulting in slow and uneven progress in maternal health. Many things have changed in the interim, but one thing remains as true today as it did then. Meaningful, lasting change is only made through the will of the people. As such, WRA launched the What Women Want Demands for Quality Reproductive and Maternal Healthcare campaign. It began with a simple idea: ask those who most use maternal and reproductive health services to tell us what they most need. Ask the clients, ask women and girls. As part of What Women Want, women and girls from all different parts of the world and all different walks of life shared many of their most intimate experiences, often in the name of helping others. Many were eager to speak up. No one had ever asked them before. In the end, the What Women Want campaign was over 1 million+ unique encounters in 114 different countries. The vast majority from India, Kenya, Malawi, Mexico, Nigeria, Pakistan, Tanzania, and Uganda. What is your top priority for maternal and reproductive health care? This open-ended question let women and girls set the agenda, as opposed to beginning with the premise of what is important or asking them to decide among a set of options. The power of first asking women what they want and then acting on their demands has proven to be an accelerant for change. And it all started in India. Arpajita, now I'd love to hear from you to share more about the origins of What Women Want.
Thank you, Christy, and thank you everyone for joining us on the eve of Diwali. Before I get to the campaign, I just wanted to say a few words about, why was White Ribbon India set up in India about 22 years back. One of the main reasons for our existence as a coalition is that we want to ensure that when we speak of women's reproductive health and rights, that we keep women always at the center of our efforts. Often when policies are designed, when programs are designed, it's done by people from different walks of lives: experts, policymakers, medical professionals, NGOs, donors, investors. But very rarely do we see a representation of the target community for whom the policy or the program is being designed. And that's the reason at White Ribbon, not just in India, but globally, we really try and seek out strategies that enable us to bring in women's voices, that we hear them, that we amplify their voices, and that we take these voices to policymakers, to powerful people, and really undertake advocacy based on the evidence that these voices provide. So Christy talked about the origin of the What Women Want campaign in India, and as she said, it began in India. And it began in 2016 and 17 when, as a collective, we were searching for ways to hear directly from women. We were looking at ways of elevating women's voices in a manner that is constructive. We do have a lot of interfaces with public in many different fields, but often what comes out is a critique, a whole list of what is not working, what entitlements people are not being able to access. But when we designed What Women Want campaign, we really wanted the findings to lead to a constructive dialogue and effective investment policy change, etc. And that's the reason why we thought that it would be really good not just to hear directly from women, but also to ensure that we focus exclusively on women's aspirations. So what do women aspire for when they seek reproductive health, maternal health services? So that's how What Women Want came about. We really wanted to highlight aspirations and not really kind of, spend all our energy in critiquing what is not working. And I think, as you can see, as you will see from the rest of the slides, at the heart of the genesis and the kind of the campaign today is really to tell people who make policies that when you hear from women, that is where, you can provide quality of care. And I think, I would want to end this section by talking about the fact that What Women Want campaign is unique, not just because it amplified and elevated women's voices, but as you would hear today, this campaign also demonstrated that it was really possible to take voices from the grassroots to subnational level, to national level, and onto a global stage in order to make an impact. So I'm going to now ask Diana to play the video which talks about the campaign before we talk about the impact. Back to you, Christy. How many women are actually asked, do you want to study further? Do you want to get married now? How many women actually have the right to decide how many children she wants to have, right? So decision making is something that women don't really enjoy. Voices are something that women don't normally have. So we went out to at least about 300,000 women in the country, and we asked them that when you go to seek health services, be it for reproductive health, be it for maternal health, what is that one thing that you really, really want?
And for a long time, they just kept quiet, like, what to say. And nobody had asked them.
हम लोग क्या चाहते हैं? What we want? Till date, nobody asked us. So you are joking with us? No, it's real. Then we have started with a small thing, and day by day it increases, and they shared their views.
मैं चाहती हूँ कि लेबर रूम में जो भी स्टाफ रहें वो अंडरस्टैंडिंग कोऑपरेटिव के साथ साथ ऐसा भी होना चाहिए कि पेशेंट से बात ज़रूर करें।
मैं चाहती हूँ कि हर अस्पताल में, हर वार्ड में एक डॉक्टर हमेशा रहे ताकि हर मरीज़ की जो परेशानी दिक्कतें हैं उसको दूर कर सके उसी वक्त।
मैं ये चाहती हूँ कि डॉक्टर लोग मरीज लोगों के साथ में अच्छा व्यवहार करें, अच्छे तरीकों से उन्हें देखभाल करें।
मैं चाहती हूँ हॉस्पिटल सेक्टर्स में वेस्ट डिस्पोजेबल प्रॉपर वे में होना चाहिए ताकि जो हम सामान्य कूड़े से किसी को इन्फेक्शन दे सकते हैं वो कम हो सके।
मैं चाहती हूँ कि एक प्रेग्नेंट लेडी को ड्यूरिंग हर प्रेगनेंसी पीरियड हर तरह की फैसिलिटीज़ प्रोवाइड हों, जैसे कि डॉक्टर्स की फैसिलिटी, नर्सेज की फैसिलिटी, और व्हेन शी इज़ अबाउट टू डिलीवर तो उसको ट्रांसपोर्टेशन की फैसिलिटीज़ प्रोवाइड हो।
मैं चाहती हूँ कि हर हॉस्पिटल में हर पेशेंट के बेड अलग अलग होना चाहिए।
We told them that in this postcard, in this piece of paper, please put in your one highest aspiration that you want. The idea was that we look at what women are asking for, and then we put forward their ask to powerful people, to policy makers who actually design and implement policies.
So we talked to tribal women, we talked to rural women, we talked to women in desert areas, we went and talked to nomadic tribes, we went and talked to women living in semi-urban areas. So there was a lot of diversity.
So the campaign, which was an Indian campaign, we started in 2017. It went global in 2018, and as of today, we have reached 1.2 million women across the world.
we came to know many things which are very basic for us as a technical person, but they are most important for women.
We looked at what women are asking for, and as you could see, women are asking for respectful care. Women are asking for no disrespect and abuse when they go to facilities. Women are asking for clean facilities. Women are asking for entitlements and a clear process of dispersing entitlements. So once we heard from women what they're asking for, we then took these asks to people who have the power to make the changes. The health minister, different members of parliament, MLAs, health officers. What we wanted them to do was to really commit to delivering on what women are asking for. Well, thank you for watching the film. I'm just going to kind of end my bit of intervention here by giving you all a bit of insights about, how did we use the data collected? How did we use women's voices in order to ensure that, there is action happening on what women have asked for? It sounds kind of, easy when you look at the film that, women wrote and we analyzed and we kind of, asked people for different things, but it wasn't that easy. So for example, when we looked at a huge percentage of women asking for respectful care, we had to go back to the data to figure out, what is it that women are really asking for? And as you could see in the film, there was a woman who asked for a separate bed for her sisters, for other women when they go for childbirth. Now, this is something that could be a given, something taken for granted for you and me, but not for multitudes of women around the world. So we really had to go back to the data to understand what were women asking for and why they were asking for it. So there was the data analysis part. And then we really looked at, now the women have asked for multiple things. There are certain action that can be taken at the national level. Other action needs to be taken at the subnational or the local level, which meant that we had to look at the findings in order to curate the right call to action for the target group. So for example, if it is meant for the minister, we asked for respectful maternity care to be part of policies. We asked for a new cadre of health workers, midwives in the country. But when it came to women presenting their demands to a local elected leader, then we had to curate it down to what women from that geography was asking for. It could be ensuring that the health centers open for 24/7. It could be ask for an ambulance to take women to the hospital. So then we did the exercise of, like I said, curating the right message for the right people who could actually make a difference. Then just putting the ask in front of important people was not enough. So we used different mediums for dissemination and diffusion of what the campaign asks. We not just did one-to-one meetings with powerful people, with policymakers, with ministers, with health administrators, but we also convened large events. Women in communities wrote a letter to the elected representatives saying, this is what we want you to ensure that we get. We produced films on the ask, which was telecast by mainstream media. We wrote op-eds, and it was really, really important to do some of these activities so that the voices of the women was heard by multiple people. Many countries, as you will hear from Christy, they were impacted in multiple countries. And when it comes to India, I just want to talk about one of the impact that we have been tracking. As I kind of shared with you, 23% of women had asked for disrespect and abuse to completely end. And in addition to looking at the data, we also undertook research, research to understand how much is the prevalence of disrespect and abuse in our health system. What are the forms of disrespect and abuse? What are the drivers? What are the causes? And does disrespect happen only in facilities which are high load, or does it happen across? Why is it happening? And we did multiple research in multiple settings, and we came back and really kind of put forward an advocacy ask about what needs to be done, not just incorporation of respectful care in policies, but also what can you do with a facility in order to ensure that respectful care norms are being followed. Like, for example, we signed a memorandum of understanding with the Aurangabad Medical College, which caters to almost 18,000 childbirth every year. We did a baseline, we developed a plan to introduce respectful care in their facility. We train providers, we train administrators, we train the cleaners and the guards in the facility to ensure that no form of disrespect and abuse happen. So these are some examples of how we not only pushed the agenda of respectful care into policies that are there in India today, but also supported the implementation of the policies. And as you would hear from Christy, there were many, many major policy wins which came out when we started advocating and sharing the evidence that came from the campaign. With this, I'm turning it back to you, Christy, to talk about some of the global wins.
Thank you so much, Arpajita. Since mid-2019, What Women Want demands have resulted in more than 20 major related policy wins and mobilization over $11 million in domestic funding for RMNCH services and supplies in those 8 focus countries I mentioned earlier. There have also been more than 350 facility upgrades that have happened as a result of the campaign. And these are major upgrades. I'm talking running water, operational blood banks, GBV, and disability services where there were none before. The campaign has also led to deployment over 2,000 healthcare workers in those countries. Facility and personnel changes are often dismissed or overlooked in the advocacy world, but these are the changes that mean most to women and girls, most to communities. They are the changes they can see in their backyard, the changes that inspire them to seek services and to continuously speak out. Part of the expression of interest for strengthening systems for safer childbirth includes stating the leading challenges to achieving sustained improvements in maternal health in the select geography, as identified by women and girls living in that region. A tool that we would like to share in detail that can be used to support this effort is the What Women Want Interactive Dashboard. The What Women Want Interactive Dashboard allows for a truly unparalleled level of access into women's demands by connecting women's voices with the almost infinite possibilities of digital analysis. It really is a one-of-a-kind resource. So when first accessing the What Women Want dashboard, this is called the default view. There are buttons at the top of the dashboard that allow users to find out more about the What Women Want campaign, watch an overview video, and activate a step-by-step tutorial that will walk you through the dashboard directly in your own time. The first step in using the dashboard is to go to the section in the upper left that features the filter tools. Within this section, you'll see 2 tabs. One allows you to drill down to get more specific information on responses by country, category, age, and even keyword. And the other tab lets you compare those groups. We'll quickly review what the dashboard looks like when you activate a country category. In this case, we'll use India. At the upper right of the dashboard, you'll now see the number of women who responded in India next to the total of all participants globally and a histogram of their ages. Directly below the filter section is the breakdown of women's responses by topic. Over 1 million responses were categorized and coded by White Ribbon Alliance, either through extensive hand coding or through digital means, including natural language processing and machine learning techniques. Our codebook separated responses into 39 categories to cover demands ranging from more and better health professionals to water, sanitation, and hygiene to respectful and dignified care. Our codebook is available online to allow anyone the chance to see behind the scenes how coding and categorizing decisions were made. Another way we attempted to be as open as possible with this work. Immediately to the right of the category bar graph is a box that shows a sample of 1,000 responses. The responses reflect the categories you have filtered for, and the samples change every time the page is refreshed. Again, there's nothing more powerful than actually seeing the words from women's mouths directly, much more even than the category. You can click directly on a category on the bar graph to go deeper dive into survey responses. We've highlighted the respectful and dignified care category here, and you can see how the survey responses have updated. The great thing about this dashboard is you don't need to take White Women Alliance's word for any of it about what women were saying, because unlike other health questionnaires, which can turn in women into unknowable graphs, printouts on a PDF, or a synthetic diagram, this allows you to see each individual response's exact words. Throughout the campaign, it became abundantly clear from the women and girls responding that they wanted to have their voices heard. They wanted this campaign to matter. This demand for openness and the desire to be listened to is at the heart of the dashboard, and you can see that most clearly here in this section. Below the breakdown of the category bar graph is a section that focuses on the top words and phrases mentioned within response demands. There are 3 views available: 1-word responses, 2-word phrases, 3-word phrases. This allows for a much fuller understanding of what was actually being asked for and how it was often phrased and grouped and paired with other demands. As we take a deeper look into women's demands in India for respectful and dignified care, we can see that rising to the top are the words behavior, respectful, and non-discriminatory. But it's a 3-word phrase tab that provides a lot of important insight. The top responses here include the phrases provider discriminate and provider assault and behavior embarrasses us, amongst others. It is clear that many women and girls felt they're being treated poorly at health facilities. They wanted to be spoken to with kindness and respect. WA India, as Aprachita said, is working to promote respectful maternity care to make sure that they are. You can spend a day, hours, and even a few seconds exploring the dashboard, finding new and more valuable insights. We want to show you one more function before we move on to our next tool. The dashboard allows for you to actually search for specific words within the million responses. So if you wanted to know what Indian woman aged 25 to 35 demanded related to water, sanitation, and hygiene, WASH, you can set those parameters with our filters. You can drill down further by searching within this category for the keyword clean. You can also exclude text from the function. If you wanted to drill deep into women's demand for sanitation and hygiene within the WASH code, but want to exclude water to gain a better understanding of the request for cleanliness, you could do that. And globally, I think it's interesting to point out, this desire for cleanliness actually accounted for 65% of women's total WASH demands. This is really quite telling. It shows us there's a huge problem with cleanliness globally. I don't think it's a coincidence either. Environmental cleanliness is widely ignored and not prioritized on the policy level. But now, with the information within the dashboard as a starting point, there's the opportunity to set the groundwork for larger programs and projects surrounding the importance of investing in environmental cleanliness in health facilities. This is just one example of how the dashboard can be used as a tool to dig deeper into what one wants. Now that you've learned a bit how to use the dashboard, we wanted to share another valuable tool with you. Developed from years of expertise in mobilizing and organizing individuals and communities to affect change, our new PowerUp program planning guide and PowerOn toolkit for community organizing are another key set of resources that can support your EOIs as well. And more importantly, your programs once they are beginning to be implemented. These power tools include practical guidance and worksheets to support women and girls in communities to identify changes they would like to see, create a program plan, and organize collective action. These tools currently support the advocacy and community engagement efforts of WRA alliances and many other partners and stakeholders. They walk you step by step through putting WRA's What We Want methodology into action. WRA's power model presented in these guides spans the advocacy continuum, from social and behavioral change communication to political advocacy. It's meant to spark changes across households, communities, and countries. Successful implementation of the What Women Want methodology and power model is intended to immediately result in improved health access behaviors and decision making. but it's also really intended to upset current power paradigms. Power model, what we want, it's unique in assuming that women and girls are inherently powerful and that there's no greater force for change than when they're at the very center, making their voices heard, determining project priorities, designing programs, and making decisions. This work, what we want, the power model, it's underpinned by the belief that women and girls are the experts regarding their own lives and experiences and know what best is needed to improve their own health and well-being. Women's and girls' wider communities and support systems, including development stakeholders, such as many of us here, can and should be consulted, included in project planning activities. But those who are expected most to benefit must also drive it. We truly believe that having access and making use of the What Women Want dashboard and Power Toolset will support all of your EOIs and your programming for the Strengthening Systems for Safer Childbirth initiative. We hope this has been helpful and want to thank you all so much for taking part in this virtual seminar. We now have time for questions, and I did see a few questions already in the chat box, which is fantastic. And please feel free to put more questions in the chat box or raise your hand. But first, we have a question from Tina. The Indian FCR regulations prohibits subgranting from a foreign grant to other Indian organizations. This means that Indian organizations cannot be the lead agency. Any ideas on how to address this? Tina, I'd love to bring you on for a moment just to provide a little bit more background and context to your question. And then Tayo, perhaps it would be great for you to first answer this from the perspective of the MSD from others. Tina, any more clarity you'd like to add on this point?
Thanks, Christy. No, this is a concern for all organizations, Indian organizations who are registered here in India and does not have a international head office, so to say. So the Indian government introduced these regulations last year, saying that if you get funds from a foreign contribution, then you cannot subgrant to other NGOs here in India, which means that none of the Indian organizations can be the lead in this coalition. And I was wondering if you have any additional advice on how to then overcome this. Thank you.
Thanks, Tina. I appreciate that. And so it sounds like, again, so much of this work is really important at the community level, different small groups who are working as close to women and girls as possible. But unfortunately, they're not always available to get money directly. And they also sound like they're not necessarily available to get money through a larger Indian NGO to subgrants. It sounds like that might be the issue. Tayo, do you want to take this one?
Yeah, sure. Thanks very much for the question. It's something that we're aware of. I think that the simple and first response is really to say that it doesn't actually stop you from forming a coalition and thinking through who you can partner with at a country level that can be that lead organization. As I said, and is within the request for expression of interest. We're really looking at coalitions and the role that you play within that coalition is defined by your value in terms of the coalition and those that you're working with. So if you want to do something that you think is meaningful and aligned with what we're asking for, by all means, look for those partners that can enable that to happen. And we're hoping to be able to support in the way, whichever way we can, aligned with the policies on the ground. So it shouldn't stop coalitions being formed, but we recognize the constraints.
So Tayo, let me just maybe clarify. So for an example, you bring a coalition together and you really like that coalition's expression of interest, MSD might consider recognizing that the group would work as a coalition, but might directly fund multiple members of that coalition.
Or the lead organization may be a lead organization, an international organization that then can act as a coordinator of the effort.
Okay. Oh, okay. So that's really, really helpful. Thank you. Tina, does that answer your question?
Yes, thank you so much.
Great, right. We have another question from Dr. Leela. Can Merck for Mothers give smaller grants at subnational level in India? And if so, how could WRA India possibly support them? So Tayo, that question might sound similar, like if there's a potential TA role, and if there are maybe smaller organizations who might be working directly but wanted to access pieces of the dashboard or elements. Dr. Leila, did you want to come in and further elaborate on your question? I want to make sure I interpreted it correctly.
Yeah, I think it's very much in line with what's already been mentioned. The fact that, you know, as a coalition, we've been working for a long time. And some tasks can be given out as contracts and others really need to be, you know, monitored and provided some technical assistance. So we're just sort of, again, wondering, because I know that in the past, FOGC has had, you know, the ability to work across its societies in India. So I was just wondering, because those societies may not be, you know, individually capable, but would be jointly possible through maybe FIGO or the whole of the India's FOGC. So in the similar lines, if we, you know, worked with other coalitions and tried to form groups with different tasks, we were hoping that, you know, perhaps right now in the EOI, we would maybe look at health systems work, which is individual organization expertise or coalitions, but specifically looking towards those smaller organizations that don't have the FCRA registration because they're too small or they're not been there long enough to actually get this kind of funding. So, I mean, it's just a heads up. We continue to try and see how we can, you know, work around the rules so that women's voices and their needs are met. Thanks.
Arpajita, looks like you want to come in. Yeah.
Yes, I mean, just to kind of.
Ooh, Arpajita, you're on mute. Yeah. Okay.
Yeah. I hit the keyboard by mistake. Anyway, so I was saying that the current rules, which were changed late last year, Leela, there is no way you can get the fund to any other entity, small, big, registered, not registered. So if the source of funding is foreign, it'll stop at the first kind of port of receiving. So unless it's a contract or you are getting something printed or you're hiring someone directly for training, there's no way you can pass it on to another entity. So, and in a larger context, this has made it very difficult for grassroots NGOs to kind of work and survive and deliver for the communities in the country because, you know, they do not have the bandwidth to bid for proposals. You know, they mainly have worked wonderfully as sub-grants. So that's something that I don't think is possible. Over.
Tayo, did you want to come?
Thanks for that.
The other constraints on our part is that as one of the regulations that we are bound by also is that we can't give any grant greater than 50% of the revenue of an organization, and that also provides some constraints in terms of, you know, being able to actually support some of the small organizations, which is why it's so important to be able to have a lead partner that can help in terms of ensuring that coalition can actually function by being the lead. But we recognize it, but I don't think this should be a constraint to actually select, you know, thinking through what it is that you want to do, and then we can sort of think about the modularities in terms of enabling that to happen if, you know, it's something that we want to advance or others want to advance.
Great, thank you, Tayo. I saw a hand raise. I believe it was from an Aditi. Aditi, did you want to come in and ask a question?
Yes, Christy. Yes, I had a question. First of all, thank you so much for the presentation. It was definitely very insightful. Now, my question is mostly relating to the approach and implementation. And the first question that comes to my mind is the role of men in the family to ensure safer childbirth of women. So I just want to understand that how are the men being, incorporated in the program, and what is their role in sort of ensuring that the program implementation is smooth? Yeah, I think that would be all.
Tayo, did you want to kind of share that from the MSc for Miller's perspective? And then I think Arpajita or myself could also chime in from a WRA perspective as well.
From Miller's perspective, it is clear that basically we all play a role in ensuring that whether it's women or other men that are caring for children or the family have a role to play. And actually, in terms of policy and helping to us to like move things forward and create change, it is clear that basically we all need to understand this. Especially when I look about, from my perspective as a country I come from, Nigeria, a lot of men are actually in the decision-making seats. And until basically we understand, they understand why they need to make certain decisions and also empower other women to make decisions for themselves and free up that space, etc. We don't create those just changes that we need. So we totally agree. I think men need to be part of the discussion, and whatever solutions actually can bring forward to actually sort of like helping us to address that, I think is a great thing, because I think the country I mentioned is not alone in terms of issues around inequalities and decision making. So welcome any suggestions.
Arpajita, did you want to come in from your perspective?
Yes, absolutely agree that programming must include men and boys. Everything I agree with, but Aditi, when it comes specifically to the What Women Want campaign, I would like to say that we are unapologetic about the fact that we wanted to reach women. As you can get from the title of the name of the campaign itself, it's What Women Want. We really wanted this to focus on what the women at the last mile is asking for. We need to hear her. So in terms of, where is men in What Women Want? That's my answer. But like I said, agreed that men and boys have a role to play, and the burden of making these changes should not fall always entirely on women. Over.
True. Aprajita, just to add on to that, I'm so sorry, Christy, I'll just take a minute, less than a minute. So my concern is, especially in the Indian context, a lot of decision-making abilities or the rights of decision-making mostly lies with the men in the family. Men or even boys in the family, they are the one who decide. So I just want to know, and maybe it's just out of curiosity, that when we actually go and ask the women that what exactly they want, how do the men respond to that? Because obviously they'll be going back to their homes, and what is the situation there? So my question was in context of that, but I completely agree with you, Aprajita, that we really want to know what the women want, definitely.
Yeah. And Aditi, even in the context, specifically in the context of maternal and reproductive health, when to have a child, how many to have, it's often seen that even in Indian societies, it's rarely the husband or the partner, it's other women and older people in the family who's deciding for the new bride that she should have a child right away to prove her fertility. And if she's given birth to, God forbid, if she's given birth to daughters, she has to promptly get pregnant again to produce sons. So it's not just the men, it's a number of other powerful voices in the society, which is primarily drowning out women's own voice and kind of, her choice. Back to you, Christy.
Thank you.
Yeah. No, thanks so much, Arpajita. Powerful answers. And one thing, Aditi, I'd just say the power tools do recognize the importance of allies and champions, of which men and boys are incredibly important, and how to engage them and how to bring them in part of these conversations that still ultimately center women and girls and are for the betterment of women and girls. So lots of tactics and approaches to do that. And I'm sure the strengthening safer systems for childbirth will be really appreciative of you looking at a holistic approach. And again, how you're using men and boys as those allies, those messengers, and really their role in helping women also reach for what they want. And one thing I would say, men and boys have been highly involved in the What Women Want campaign as mobilizers. One of the original architects of the campaign was, a gentleman among there were several gentlemen within WRI India who really, created this campaign along with some incredibly talented and intelligent and wonderful women. And I would also say, I've been really pleased to see how much there has been positive response from so many men and boys about this. And it has even been illuminating when they think they know what their wives want, and then they realize, oh, we don't necessarily. I think that's a really powerful moment where we've seen more pushback is truly actually at, funding levels sometimes. And that's why I just really do want to say it's so exciting to see a big, large funder and donor who are really thinking about, okay, how do we listen to women and girls? Because we don't know the intimate details of their lives. They know better than anyone what are the barriers, what are the challenges, and how they need to maneuver and navigate to really follow their needs. And that includes often the systems working with and against men and boys, and sometimes how to navigate that decision making. So I think that's a really important piece as well. Other questions? We have time for maybe one or two more. All right. If we have no more questions, just turn it over to Arpajita and Tayo for any sort of last reflections and words.
Not much from me, actually. I'm just kind of taking the opportunity of wishing our colleagues from Work for Mothers all the best. We hope that you get some really game-changing proposals. And we are here as part of the community to help the process go a long way. Over.
Yeah, and thank you so much, Brigitte and Christine, and for everyone else that's joined. Really appreciate the time. And like I said at the beginning of this session, we really do believe in this. We, believe it's not just a nice to do, but it's actually fundamental to also making it sustainable change in how we provide services and ensure that basically going forward, we have services that are responsive to the needs of our communities. So thank you for everything that you're doing, and look forward to all the EOIs.
And thank you, Tayo. Thank you, Arpajita, for sharing about the origins of the What Women Want campaign and the generosity of you and so many of your colleagues to support this methodology going global and really changing, I think, how so many are approaching health and development. And thank you for answering questions and showing more insight for what you learned in India. And then, Tayo, again, really want to thank MSD for Mothers for developing such an exciting initiative that we're thrilled leverages this methodology and this philosophy of listening to women. It really is, a transcendent approach, one that I've seen work in here in my own hometown in Washington, D.C., where local communities addressing maternal mortality are taking on housing issues, because that has actually been what's found to be the biggest contributor to poor maternal health outcomes in my city. It's housing insecurity. And nobody was looking at that issue until a similar initiative by MSD for Mothers in the United States. So just want to say thank you and for taking that approach global as well. And then I just want to say to everybody else, listen to women. Look at the dashboard. You may think you know what women want, but you'd be surprised. I myself just, When I started working on this campaign as one of the co-chairs, I was sure I knew the #1 answer. Turned out to be number 13. And I thought I'd been doing this a really long time. I didn't know. And there's so much shades of nuance that are available in the dashboard. And so please explore that as a resource, and also keep asking. It shouldn't be a one and done question. Keep asking women, keep asking communities as you develop your EOIs and you develop your program. Good luck to you all, and please do not hesitate to follow up if you have any other questions on any of the tools. Goodbye, everyone.
Thank you. Goodbye.